Recording in progress. Good afternoon, colleagues. Those in the room, welcome back. And those online, I would like to welcome you to the afternoon session and apologize for the slight delay in starting. We arrived a little late back from the fieldwork, but now we are ready to start our session, session 5, where we will have presentations, 4 presentations, on different aspects of case management. We have, the first is the triple artemisinin-based combination therapies. The second, by Mehul from the Mahidol Oxford Tropical Medicine Research Institute. And the second will be the impact of the private sector co-payment mechanism on the private market for ACTs in Nigeria by Emmanuel Shekarau. And then we will move to assessing the influence of psychosocial factors on provider malaria case management in Benin by Stella Babalola. And then we will hear from Professor Roger Tin on identifying operational research and program evaluation priorities for malaria case management for sub-Saharan Africa. So all presenters are here, and we have Professor joining us online. And without much ado, I would like to welcome Mehul to come and give his presentation. After all presenters have presented, then we will have the discussions, the questions in a panel format. Thank you.
Good afternoon, everyone. It is a pleasure and a privilege to have the opportunity to speak to you about the DTAC project. So, of course, I would like to thank the organizers of this meeting for inviting me to speak on behalf of many, many DTAC project investigators about that project. So my name is Mehul Dorda. I work at the Mahidol Oxford Tropical Medicine Research Unit in Bangkok, and I am the coordinator for the studies being conducted in Africa for the DTAC project. I'd like to begin actually by thanking all of the many, many collaborators that we're working with on this project. I just want to make sure that I get that in right at the start, just in case I run out of time at the end, and I would hate to skip this particular slide. So thanks to all of our collaborators. I will mention them as we go through the talk. So I'd like to begin just by a very brief overview of the emergence of partial artemisinin resistance in East Africa. I will not go into details, of course, because we had a really excellent overview from Dr. Ringwald yesterday. But I just wanted to mention that, of course, that in both these countries, in Rwanda and in Uganda, this is now genotypic and phenotypic confirmation of partial artemisinin resistance. And as we discussed yesterday, that in Uganda, where transmission is relatively high, we're still seeing the mutant parasites becoming more and more prevalent year on year. As Dr. Ringwald mentioned, one of the possible reasons for that is that the mutant parasites produce gametocides earlier and produce more of them, which means that they have a certain transmission advantage. And in that context, actually the use of single low-dose primaquine might become quite important quite soon. Just to go back to what happened in Southeast Asia, so in about 2007, 2008, there were some studies conducted which first defined the phenotype of what we now call partial artemisinin resistance. At the time, we did not know that it was associated with mutations in the PF-Kelch gene, or the falciparum Kelch13 gene. We know that now, and based on that knowledge and also on the knowledge of the marker of resistance associated with piperacin resistance, we are able to do some molecular epidemiology studies. You can see that in the central panel over there. So after the emergence of partial artemisinin resistance, those parasites also acquired eventually piperacin resistance, and they basically ended up taking over or becoming rapidly very dominant in the parasite population in Cambodia. And that's what you can see in the green color over there in the central panel. From there, the parasites ended up spreading to Thailand, Laos, and Vietnam. And that's where, there were a few clinical studies that were done. I will talk about one of them, which showed treatment failure rates as high as 60 to 80% with DHA piperacin. So, by the way, I should say that this happened in Southeast Asia. This is not to say that this is what is going to happen in Africa, but we do need to remember that once partial artemisinin resistance is combined with piperacin resistance, that's when we start getting treatment failures, and that's really what we need to be monitoring for and be ready to react if and when that happens. So just to illustrate that point, I'll talk about two combinations, two ACTs. So on the left, there is artesunate mefloquine. On the right, it's about DHA piperacin. On the left, so these are actually data from the Thai-Myanmar border. What you can see on the graph is the black bars represent the proportion of parasites which carried the mutations in the PF-KELS13 gene. And then the white bars represent the parasite that had mutations that confer resistance to mefloquine. Now, as you can see, even when the mefloquine resistance, the prevalence of mefloquine resistance was very high, the treatment efficacy, which is the red line on the top over there, actually stayed really, really high. But the moment the KELS13 mutations and the mefloquine resistance conferring mutations reached a certain level, the efficacy plummeted. You can see the same thing on the right-hand panel. So the line which is going down the furthest, so that's actually represents parasites. It's a survival curve of infections with parasites that have the KELS13 mutation and the mutation which confers resistance to piperacin. With both of these mutations, obviously you see a great reduction in the efficacy of those combinations. So here again, Dr. Ringwald talked about this, why partial artemisinin resistance is important and how it can affect actually ACT efficacy. So what you can see on this graph is the light gray line represents the parasite clearance of artemisinin sensitive parasites. But with artemisinin or partially artemisinin resistant parasites, what you see is the black curve. And then the shaded area is the amount or the increased biomass of parasites that are exposed to the partner drug. So this means that the probability that resistance will emerge to the partner drug increases when there is partial artemisinin resistance. So to counter that, what you could do, which is what we have tried, is to use two partner drugs. So for a parasite to become resistant to this triple combination, it would actually have to be mutated, have three separate mutations. And the probability of that happening is really very, very low. And it ends up actually creating mutual protection between the partner drugs in the triple combination. So before actually getting into the triple combinations, we have to think about two particular conditions. Number one is that the PK profiles of the two partner drugs need to be reasonably matching. Now, as we all know, artemisinins actually they disappear from the bloodstream very soon after drug administration. But with the partner drugs, they actually end up staying in the bloodstream for a couple of weeks, if not more, for some of the partner drugs. So we need to make sure that the PK profiles of the partner drugs are matched so that at any given time, the parasite is exposed to at least two partner drugs. And the second condition is that we need to have some kind of counteracting resistance, or at least the resistance mechanisms need to be different. Because if a particular mutation confers resistance to two different drugs, then obviously you don't want them to be used as a triple combination. So one of the first combinations that we thought about was the artemethyl lumefantrine and amodiaquine. So as you can see on the left panel, the PK profiles of lumefantrine and amodiaquine are reasonably similar. And for now, we have in vitro indirect evidence showing that lumefantrine-resistant parasites actually become sensitive to amodiaquin and vice versa. So that's the panel that you can see. I'm sorry, the figure is really small, so you may not be able to see. But it's essentially, these were experiments done by Professor Fiddick's lab, where they took the same parasites and introduced different mutations in a particular gene, which allowed them to basically show that with one particular mutation, the parasites were sensitive to lumefantrine and resistant to amodiaquin and vice versa. The second combination is artesunate mefloquine and piperacin. So mefloquine and piperacin both have reasonably long half-lives, so they stay in the blood for quite a while. And then here again, we do have kind of indirect evidence about resistance to mefloquine and piperacin. So what you can see in the bottom right panel, I'm afraid the colors are not very clear, but in the green, let me see if I can use the pointer here, just a second. Yeah, I think, yeah, you can see the pointer here. So this actually represents the prevalence of piperacin, of the marker for resistance to piperacin, and then the other line, which is going downwards, is the prevalence of the marker for resistance to mefloquine. So with these two, you can see that as the piperacin resistance went up, mefloquine resistance went down. This might just be a simple result of the fact that the treatments were switched from artesunate mefloquine to piperacin. So it might reflect that, but the fact remains that at least the mechanisms of resistance are related to two different genes, and they have not actually been found in cervix except in one study. And even that study, actually, there are some doubts about the methods that were used. So we can be reasonably certain that they could go together, at least with respect to the resistance mechanisms. So these two combinations have actually been tried already in a couple of studies. So I'm going to talk about the TRACK-2 and the TAC-CV studies. So these are studies conducted by my colleagues Rob van der Pluijm and Tom Pito. The TRACK-2 study was conducted in the 5 countries of the Greater Mekong sub-region and also in India and the DR Congo. And the TAC-CV study was conducted in Cambodia and Vietnam, which is where the CV comes from. So in the TRACK-2 study, we tested the combinations artemether, lumefantrine, amodiaquin versus AL, and also dihydroartemisinin, piperacin plus mefloquine versus artesunate mefloquine. And just, I don't want to go into the details of those studies. These have already been published, so I invite you to download those papers and read them. But just to give you the headline conclusions from the trial. So the efficacy of the triple ACT was much, much higher than the efficacy of DP, or dihydroartemisinin piperacin, in Cambodia, Thailand, and Vietnam, where as I showed before, the treatment efficacy of DP was really, really low. However, when you compare the efficacy of AL and AL plus AQ or DP plus MQ versus the other standard ACTs, they were similar in the other countries. I should mention that actually when we started the trial and when we noted that the DP efficacy was really low, we actually changed the comparator arm to ASMQ from DP. So that's why we have lots of results from DPMQ versus ASMQ as well. So that's in terms of the efficacy. In terms of the safety and tolerability, so overall it is similar to ACTs. There is a slight but significant increase in vomiting in the patients who receive the triple ACTs. With respect to artemether, lumefantrine, and amodiaquin, actually it is slightly higher, but it is similar or even lower than what you would expect to see with artesunate amodiaquin. And also, perhaps importantly, this is the combination that was trialed in the DR Congo in children. And in that subpopulation, actually the vomiting rates were quite similar between the triple and the standard ACT. We also see some mild to moderate or transient increases in bradycardia, in creatinine grade 1 or 2, adverse events, This is basically giving a very reassuring picture in terms of the safety of the trial. So at this point, I'd like to get into talking about the DTAC project, which will be basically the rest of this presentation. So based on the results from the Track 2 study, we decided that we need to develop this triple into eventually a fixed dose combination, which is coming. But for now, we are conducting actually the DTAC trial with artemether lumefantrine and amodiaquine. The DTAC project, just like the Track 2 trial, actually have been funded by UK aid from the UK government. So the DTAC project actually is a kind of multifaceted project in the sense that we're not only doing the clinical trials, but we also did some bioethics and market studies, with the idea being that, if we are able to confirm the reassuring safety and efficacy data from on the triples, then we should already be thinking about the rapid deployment of the triples. So with that in mind, we started with some bioethics and market studies. So the bioethics part is actually quite interesting and important because when you're giving triple ACTs to a patient, you're essentially exposing that patient to a slightly higher risk of slightly more side effects. And then the question then becomes, is it justifiable for the individual patient to be exposed to these slightly higher side effects, with the fact that with the benefit really being for the population in the longer run. So the best way to resolve this, we thought, was actually to speak to the patients and other stakeholders. And essentially, it sounds like everybody is okay with the side effects. But they do sort of recommend doing community engagement to facilitate the deployment. In terms of the market studies, so these studies, by the way, I should mention, were conducted before the confirmed reports of partial artemisinin resistance. And at the time, the stakeholders, and these included, by the way, people from programs in Burkina Faso and Nigeria, they felt that this triple ACTs would really be successful if there was ACT failure. But they also recommended, trying to get the WHO and the Global Fund on board, and also getting the triple ACTs approved as soon as possible. And they also recommended the community engagement. The other studies that we've been doing are modeling studies. I realize that I'm running out of time, so I'll just jump to the headline conclusions. But essentially, the use of triple ACTs could delay the emergence or spread of multi-drug resistance. And over 10 years, they will definitely reduce, at least this is what the modeling says, the numbers of treatment failures. There's a bit of a tension with some of the other conclusions and what we got back in from the bioethics and market studies. But it just underlines the fact that we need to be doing some community engagement to make sure that the drugs, if they're deployed, that they're deployed quickly and rapidly. So getting into the DTAC trial, so it's being conducted at 11 sites in 11 countries. In Burkina Faso, we're working with Professor Jean Bosco Ouedraogo at INSTEC. In DRC, it is with the Moro unit in Kinshasa and the Kinshasa School of Public Health. In Guinea, it's the center in Mafarenia. Gambia, it's the MRC. In Niger, it was with Epicentre in Maradi. In Nigeria is with Professor Mokwolu in Semtrod in Ilorin. In Rwanda, of course, we're working with Aline and Jean-Louis, who I think are in the room, and the University of Rwanda, so Professor Leon Mutesa. And in Tanzania, we're working with the National Institute of Medical Research. In Bangladesh and Cambodia, we actually are working with our own sister units, but in collaboration with the Chittagong Medical College and the CNM, and in Indonesia, it is with EOCRU. So we're testing these new formulations with slightly optimized doses of artemether lumefantrine amodiaquine and artesunate mefloquine and piperacin. So as you can just very simply see from the pictures over here, the artemether lumefantrine amodiaquine combination is far further ahead in terms of development. For the artesunate mefloquine piperacin, we're actually using tablets that were specifically made for the trial and will need to be formulated. So to get into the trial design, so it is a randomized controlled, partially blinded, non-inferiority trial. Randomized controlled is obvious. It is partially blinded because the patients and the doctors know whether the patients are getting the artemether-lumefantrine-based treatments or the artesunate mefloquine-based treatments, because of, the treatment regimens are quite different. And overall, we're aiming to recruit over 3,800 patients. But obviously, that's the target. We'll see how many we get right at the end. So the primary objective is, of course, efficacy, but then we're also planning exhaustive safety and tolerability analyses. So just to get into the preliminary results, so in terms of the efficacy, the PCR uncorrected efficacy is similar between triple ACTs and ACTs. So we haven't done the PCR corrections yet. So yeah, I mean, there might be a site where actually the uncorrected efficacy is much higher for the triples, but the numbers are small, so we're not going to draw any conclusions from that. And also to mention that we're so far not seeing any delayed parasite clearance outside of Cambodia. I should there also mention that at the time we did not have patients from Rwanda. Since then, of course, we have recruited patients in Rwanda, and this will probably change the next time we do the interim analysis. Then getting into the safety, before I do this, apologies. There might be some errors on this slide. I will point them out. I did get an update, but I sent it in too late, so I have to live with the consequences. Really sorry about that. So in terms of all of the safety outcomes, so obviously we did symptom checks, we did hematology and biochemistry. So as far as those standard parameters are concerned, the numbers of adverse events are roughly proportional to the numbers of patients. So really doesn't look like there are any particular safety signals. In terms of the ECGs, I should mention that, and actually that's one of the errors on the first column. It refers to the numbers of patients who had a QTC prolongation by over 500 or a QT prolongation by over 500. None of the patients had that, but with the triples, we did see more patients who had QTC corrected, so corrected prolongation by more than 60 milliseconds from the baseline. So that was more common with the triple ACTs. And then finally, in terms of the serious adverse events, so there were 9 in total. And this is the last slide, so I'll jump very quickly through this. So there were 9 serious adverse events in total. Out of those, 2 which were related to the AL-based arms, and they were thought to be either possibly or probably related to the treatments. And then 1 with the artesunate mefloquine, which was actually a QT prolongation to more than 500. The QTC was 479. And this was out of the 500 that were included in the interim analysis, but I'm reporting them anyways. So that was the last slide. So again, thanks to all of our partners in the countries where the trial has been conducted, and also want to thank Dr. Chanakya Amaratunga and Professor Arjen Dondorp, who are also the coordinators and PI of the project. Thanks very much.
Thank you very much, Mehul, for that presentation. Colleagues, if you have any questions, please hold them. For those online, if you have any questions, please send them in, either type or send to Constantina, and we will endeavor to answer them during the panel. I would now like to invite Emmanuel Shekrao from the NMEP in Nigeria to give his presentation.
Good afternoon, everyone. So I'm Dr. Emmanuel Shikaro from the National Malaria Elimination Program, Nigeria. I'm here to present the work the survey conducted in Nigeria on behalf of all other authors. I'll start by thanking the organizers and also the Malaria Consortium for supporting the study. So looking at the background, in Nigeria, the private sector constitutes the majority of client patronage, as it constitutes 66% of patronage. And as a core intervention for the control of malaria, appropriate and timely case management through diagnosis and treatment is an essential malaria control intervention. And the positive cases are meant to be treated with a quality assured artemisinin-based combination therapy. So to improve the accessibility and affordability of quality assured ACTs within the private sector, affordable medicines. Okay, thank you. Affordable Medicines Facility for Malaria, AMFN, which was mainly supported by the Global Fund, began operations in 2010. It later transitioned into the private sector co-payment mechanism which operated up until 2017. So the aim of the private sector co-payment mechanism was to subsidize the cost of quality assured ACTs that had been through the World Health Organization pre-qualification. We know that the quality assured ACTs are those ACTs that had undergone pre-qualification by the World Health Organization. So Nigeria happens to be one of those countries that benefited from the private sector co-payment mechanism, which saturated the private sector market with subsidized ACTs in the private sector market in Nigeria. And currently, the prevalence of malaria in Nigeria stands at 23%, and it has a very large private sector pharmaceutical market. So at the end of the private sector co-payment mechanism, we set out to conduct a national outlet survey of private pharmacies and PPMVs, which was conducted in 2018. So the objectives of the survey is as clearly itemized, is to assess the state of the private sector ACT market in Nigeria at the end of the PSCM. Also to ascertain the current status of the ACT availability, the gaps in the market share and prices of the different anti-malaria brands. One of the objectives was also to determine the household use of the private sector, demand for ACTs, brand preference, and factors affecting purchase decision. Also, to provide a baseline assessment from which the market could be monitored once the subsidy scheme had been removed. So this survey was also aimed at providing that baseline such that we would compare subsequently, and also to assess the impact of the private sector co-payment mechanism on the ACT market. So we had two methods. That's one for the outlet survey. And for the outlet survey, it was a cross-sectional outlet and household survey. Generally, the survey was a cross-sectional survey for both the outlet and household survey. It was conducted across the 6 geopolitical zones. And you can see from the map there that Nigeria has about 6 geopolitical zones. And in each of those zones, the states that were selected were randomly selected from each of the zones. And in each of those states, we had the local government areas selected randomly, and the second local government area was also purposely selected such that we'll have a mix of both the urban and the rural local government areas. And it will enable us to also extrapolate the selection of the PPMVs and the pharmacies, because in the rural areas have more of the patent and proprietary medicine vendors, while the pharmacies have more of the, are usually more in the urban settlements. So the sample size was determined, that was 768 outlets were determined, assuming population size of greater than 20,000 for demand-side market system, with a 50% response rate, 5% error margin, and 95% confidence interval with a design effect of 2. The data were retrieved and proportions compared among the subgroups using binomial test for difference in proportion or chi-square test for the trend, and the p-values significant at p equals to 0.05. So the data for both surveys was collected digitally using the tablets and also digitized questionnaires using the Lime survey software version 2. Data were downloaded on the Excel and then transferred to the SPSS for analysis. The second method was that of the household survey, and we had households were selected from 4 of the 6 states to represent each of the 4 malaria endemic zones in Nigeria. And the malaria endemic zones are categorized into states with prevalence 1 to 10, that's in category 1, then 10 to 30, category 2, and then 30 to 50, and in the third category, and those above 50 are in the fourth category. So the low-income households in both urban and rural areas of Nigeria were surveyed. Proposed sampling of the 3 low-income segment was conducted, including the household with monthly incomes. So those incomes are in the Nigerian currency, those with less than 18,000, which at that point this was conducted, 18,000 was $50. And then the second categories are the $50 to $100, and the third 100 to 280. The sample size of 384 outlets were determined, assuming population size greater than 20,000 for the supply side market, with a 50% response rate. A 5% error margin and 95% confidence level was used. So now to the results. So on the availability of the ACTs, the antimalarials and both the ACTs and the non-ACTs were universally available at 99.6%, and a confidence interval of 98.7 to 99.9. And for the ACT medicines, including any ACT, whether the non-green logo or not, were at 97%, 97.6% at confidence interval 96.1 to 98.6 respectively. So the coverage of the green leaf ACTs. So the green leaf ACTs are those ACTs that are subsidized, while the non-green, and the subsidized ACTs are the quality assured ACTs. So the green leaf ACTs was very high at 80.7%, at confidence interval of 77.6 to 83.6. So the results on the availability and market share of the specific ACT brands, the most frequently stocked antimalarials was the non-green leaf ACTs. And usually they are the non-quality assured ACTs. And we had brands like Lonat, which stood at 53%, and this was followed by the non-ACT antimalaria, that's Fancida, which is usually the sulfadoxine pyrimethamine, which is used for intermittent preventive treatment. And another non-green leaf ACT is the non-quality assured ACT is another brand called the P-Alaxine, which is dihydroartemisinin piperacin. and the availability was at 47%. So the most available green leaf ACT medicine, that's the quality assured subsidized ACT, were the convene at 45% and Coartem 41%. So this table is showing the median retail price of the different types of anti-malarial among pharmacies and the patent proprietary medicine vendors. So it had attempted to analyze the cost of the ACT across, starting from the after the deployment of the private sector co-payment mechanism. For the private sector, for the green leaf ACTs, the prices, though increased minimally from 2011, that's 0.91 USD to $1.47 dollars. And if you compare with the non-green leaf ACTs, you will realize that the prices went down for those periods. So the prices reduced, which showed that the green leaf ACTs, that's the subsidized ACTs, sort of kind of forced the prices downwards for the non-green leaf ACTs. So for the results of the demand-side household survey, the household treatment seeking and demand for ACTs, the household mostly reported seeking treatment from public hospitals. That's 65.1%. And this was followed by the patent proprietary medicine vendors at 34.2%, and then private hospitals, 24%, and the pharmacies, 10.6%. So seeking treatment from public hospital was significantly more among households in northern states. So the northern state of Nigeria has lower private sector providers compared to the southern parts of Nigeria, and the population of the northern part of the country is more. And so the survey clearly showed that the seeking treatment from public was significantly more. For the ACT awareness and brand choice, among all households, that's 62% with a sample size 299 reported knowing about ACTs. So the knowledge of ACT was significantly lower in the southern states, 42% at p-value 0.01, and in lower income households, 55%. In households with less than 18,000 naira income, that's less than $50, versus the 79% in household with income greater than 100,000. So the price of the ACT medicines and impact on consumer choice, almost 2/3 of the households, 63.9%, reported that the price of ACT medicines had increased in the previous 12 months, with 50% reporting a greater than 10% increase. And the survey was conducted shortly a year after the subsidy was removed totally, and so there was a report of increase in price subsequently. So this chart is still showing the same result I just presented in the previous slide. So looking at the discussions and comparison with other studies or surveys conducted, the analysis of the 2018 market survey, particularly in relation to the previous ACT survey watch, shows clear impact of the private sector co-payment mechanism in increasing ACT availability and affordability across private sector outlets. ACT availability was almost universal among the PPMVs, that's the patent proprietary medicine vendors and pharmacies, while availability of the green leaf ACT medicines was very high at 80%. So in comparison to previous ACT surveys, the 2018 market survey that we conducted shows availability of ACT and the green leaf ACT medicine significantly increased over the time period of subsidy scheme. Improvement in ACT availability were among the PPMVs, as opposed to the pharmacies, among which availability remained steady. And this is important since the PPMVs were mostly frequently visited by lower income households and then by the household in rural areas with increased malaria prevalence. As a matter of fact, the PPMVs in Nigeria enjoy up to 51% patronage of clients seeking treatment for fever. So in conclusion, the private sector co-payment mechanism had clear impact in increasing the reach of subsidized quality assured brands and non-subsidized brands. Increased market competition led to the innovation from the unsubsidized brands and large reduction in cost to make them competitive and subsidized with the subsidized brands. So like I reported, we had clear decrease in prices of the unsubsidized brands due to the competition that they got from the subsidized brand. And so continued monitoring of the market is recommended along with improved local capacity for quality assured certification and monitoring. So we want to really acknowledge the following: the National Coordinator of the National Malaria Elimination Program in Nigeria, the Head of Case Management, NMEP, who is also here present, and then the NMEP Global Fund Project Manager, the Malaria Consortium, that provided the funding and also technical support. We also appreciate the UK government, Foreign Commonwealth Development Office, FCDO, the Senior Research Advisor, PSI, the Chairman, CEO of Innovation, and then the malaria sector private stakeholders in Nigeria. Thank you very much for your attention.
Thank you very much, Emmanuel, for that presentation. I would now like to call upon Stella to give her presentation on assessing influence of psychosocial factors.
Good afternoon, everyone. So I'm going to present results of a survey that we did, an assessment that we did in Benin Republic last year, November, December. This is a study. Let me start by appreciating PMI for funding this study. Okay. So I'll start by describing the context and the methods that we used. This is the map of Benin Republic. It's one of the smallest states in West Africa, where the risk of malaria is actually very high. The entire population is at risk of malaria. It's a leading cause of death, morbidity and mortality, especially among children aged less than 5 years. Malaria accounts for about 47% of outpatient consultations in the general population, and about 50% among children under age of 5, and 39% of hospitalization in children under 5. So, like I said, the entire population is at risk, but we could see here that there are variations by region, especially when we look at, that the northern part, the darker the color, the higher the prevalence of malaria. And this is showing actually the results from the DHS 2017-2018 DHS among children ages 6 to 59 months. So we all know that provider behavior is very important in case management. There is no gainsaying that. And we also know that provider behavior is not just it's not just affected by a single factor, but actually is affected by complex and complicated factors that operate at various levels, at the level of the individual provider, at the level of the facility, even at the systemic levels. We have seen in other areas that psychosocial factors, that is, those factors that reflect the way people think about behaviors, are very important to determine the way we behave. However, as far as provider behaviors are concerned, little attention has been paid to psychosocial variables, the role of psychosocial variables, and this is where I believe this study as a way to make contribution to literature. Now, so like I said, this was a study conducted in Benin in last year, November to December, and we sampled, there are 12 departments, or if you like, region would be better, in Benin, which was, and we randomly selected from each department a number of facilities with using probability proportional to the incidence of malaria as per 2019. At the end, we sampled 128 facilities with 366 health workers in those 128 facilities, and we focused on 1,245 patients with fever. The providers were interviewed with structured questionnaire to assess socio-demographic and psychosocial factors affecting the practices. We also interviewed the clients to see, to collect their perceptions about the interaction with the client. And we also interviewed the facility manager, as well as we did an audit of the facility itself. What are those equipment and supplies available in the facility? So for the analysis, we did multivariable logistic regression. The dependent variable here is defined as correct management of fever. That is, testing the patient and prescribing ACT if the patient is test positive for malaria, or not prescribing ACT if the patient did not test positive for malaria. And then we included in our estimated model, we included client socio-demographic characteristics, provider psychosocial characteristics, as well as the facility characteristics. So we did logistic regression, but then we limited our analysis only to facilities where testing was available on the day of the survey. And out of the 128 facilities, only 88 facilities. So that again tells us what's the magnitude of the challenges. So let's look at some of the results. As you can see here, almost two-thirds of the let's say at least more than half, more than 50%, more than half of the cases were tested. Of the cases presenting with fever, 57% of them were tested for malaria, even in facilities where testing was available. 84% of the tested and positive cases were given correct treatment for malaria. But then look at this, about 1/5 of the cases that tested negative received anti-malaria. And of those cases that were not tested, 57% received an anti-malaria. As we can see here, that the greater issue is actually with testing. Once the patient is tested, the probability is high that the correct management, will take place. It is first and foremost with testing. And we also see here that correct management actually varies by facility. It is less in private institutions compared to any other form of facility, with only barely 10% of the cases in private institutions, private health facilities being tested and correctly managed. So I'm going to go to the logistic regression results to see what are those factors that are associated with correct management in facilities with testing available. First of all, we see here that, for some weird reasons, adolescents or older children are more likely to be correctly managed compared to infants, compared to children under 5. Supervision, for some curious reasons, supervision has a negative association with correct management. That is, the more the facility is being supervised, the less likely it is that clients will be correctly managed. And that, for me, is an unexpected finding. We see here also that training matters. The more health providers in the facility are trained, the more likely it is that patients in that facility will be correctly managed. The odds ratio is more than 8, which is huge. Here now, we also see that knowledge matters. The knowledge of the individual, of the provider vis-a-vis case management is positively and strongly associated with correct case management. We also see here that, what health providers believe about the behaviors of their co-workers or their colleagues is positively associated with a patient being positively managed. What is that telling us? That's telling us, that speaks to conditional compliance. That is, I'm influenced by what I see my colleagues do. So if I believe that my colleagues comply, I'm also likely to comply. And then we see a strong association also with the proportion of positive cases in the facility. That is, the more in the facility, the more positive cases are encountered in that facility, the more likely it is that providers will actually comply. What is that saying? That's saying that probably that practice makes perfect. The more they are used to doing this, the more likely it is that they will continue doing it. Then we see a positive, but marginally significant association. Okay. But provider attitudes towards case management, we expected that to be positively associated, but there's no association with the outcome. So putting all that together, what are the recommendations? First of all, the results go a long way to show that psychosocial factors of the provider matter. The way they think about their behavior, the way they think about their actions, the way they perceive, what's going on around them actually matters. So to improve provider adherence to case management guidelines, programs may consider strengthening technical knowledge of providers, as the results show. And then using a norms-based approach to address negative beliefs of providers about the professional behaviors of their colleagues. That is, strengthening that in the notion of, for example, in this facility, this is what we do. So creating a culture of compliance within the facility. It's not just enough to target individual providers. It is necessary to look at the entire body of providers in a client that will ask, oh, you have not tested me for fever, but you are giving me medication, a knowledgeable patient. So efforts to improve provider adherence to case management guidelines will also benefit from paying special attention to private clinics. What is it about them? How can we strengthen them? How can we make the providers more compliant? And then better understanding and addressing the reasons for the negative association between provider supervision and adherence. And I ask the question here, could it be that poorly performing facilities are the ones that are targeted for supervision? And then emphasizing the importance of adherence to guidelines irrespective of patient's age. It is important no matter they comply. Before ending this, I want to say a special thank you and acknowledge my co-authors. This is an effort from multiple institutions, and we have people from PMI, people from CDC, people from the Integrated Health Services Activity in Benin, and Johns Hopkins University. Thank you very much.
Thank you very much, Stella, for that presentation. Again, colleagues, we will bring them all back to the panel. Professor Roger, can you confirm if you can hear me?
Hi, Elizabeth, I can hear you. Can you hear me?
Yes, we can. We can hear you very well. So if you're ready, please go ahead and give your presentation. You would be able to advance your own slides, but I will do it manually for those in the room here. Thank you. Go ahead.
Yes, thank you very much, Elizabeth, and thank you to all the audience and the committee organizers for giving us the opportunity to share these outputs from the research prioritization process. I am pleased to have this talk on behalf of the PMI Insight Consortium. Some of you have participated in this process several months ago, and we are very grateful for your invaluable input for this. Identifying operational research and program evaluation priorities for malaria case management for the sub-Saharan African region. Just to put some background on this, why do we need to do research prioritization? At the time of stated progress on malaria control and elimination, malaria control programs need strong guidance on how best to deploy the most effective intervention to reach the strategic goal. There are several challenges to do that because there are limited opportunities to coordinate and identify pressing gaps in research that have broader relevance across multiple countries or for the global malaria community. The second challenge is related to limited resources that are available for operational research and program evaluation. This calls for the need to prioritize our efforts in order to effectively guide malaria control program in implementing the intervention. And this has led to expression of interest from global donors, including PMI, the Bill and Melinda Gates Foundation, the Global Fund, to align research investment with country-identified research priorities. With these priorities, next please. The Insight Consortium has identified two objectives that has led to this resource prioritization process. The first objective is to facilitate a process with national malaria programs, malaria endemic research institutions, as well as implementing partners and funding agencies to identify a set of country-driven research priorities to address the most pressing effective gaps and operational bottlenecks in malaria control and elimination. The overarching aim with this is to provide stakeholders with a global good that could be used by various funding agencies in this space, as well as by malaria stakeholders for informing the selection of operational research and program evaluation topics for investment moving forward. The second objective for this prioritization process was to foster alignment between country priorities and those of funding agencies to support improved coordination, collaboration, efficiency, and impact of research effort. Next slide, please. So based on these two objectives, the INSIGHT Consortium has conducted several efforts to define a clear scope for this prioritization process. Several discussions were held between PMI, Global Fund, and the Bill and Melinda Gates Foundation to set clear boundaries for this resource prioritization process. And this scope including operational research and program evaluation question provide for approaches and tools designed to improve the delivery and effectiveness of preventive malaria control and elimination interventions. By doing so, the scope could not include what we call upstream research related to the early development of new tools, nor routine entomological monitoring for evaluating insecticide resistance or therapeutic efficacy studies of anti-malarial drugs. Overall, the aim was to identify common operational research and program evaluation questions that could provide learning to inform multiple national malaria program strategies, policies, or implementation. Next slide. And then during this process, we engaged with several stakeholders. Some of you are in this room. I remember Aline and Dr. Emable, among others. Forgive me if I don't say other names, but we engaged with National Malaria Programs representative, research institution from malaria endemic countries, donor agencies, WHO, related to global malaria program staff and country and regional level. Some of you also are in this room, as well as global technical partners who support NMCPs in the daily implementation of their interventions. Next slide. The prioritization process was conducted in several steps. We started by the phase one, which was focused on designing the resource prioritization process. One output from this phase was a framework document that was produced to guide the second phase, as well as the subsequent phases. During the second phase, we conducted a synthesize and document review based on the previous resource prioritization process that were conducted. And the document review has allowed us to provide to stakeholders an interview guide where we identify key thematic areas that were our main focus. And during the stakeholder consultation process, we engaged with National Malaria Program, research institution, and other partners. The stakeholder consultation process was focused on collecting information related to stakeholders' perspective with regard to operational challenges and bottlenecks, evidence gaps in malaria programming, and related to these gaps and operational challenges, what would be the most effective research question that would help programs to overcome these gaps and challenges. We ended up by evaluating the identified resource priorities by setting up an external evaluation committees, and we are now on the fourth phase of this process, which is focused on disseminating and tracking process regarding the resource prioritization process. Next, please. The stakeholders consultation covered several countries from West, Central, East, and South region in the Africa. And we conducted interviews with 14 national malaria programs, 11 research institutions, and 4 interviews with WHO representatives across 6 countries, 18 interviews with funding agencies. In addition to that, an online survey was conducted, and we gathered 46 respondents with input from 18 countries in sub-Saharan Africa. Next, please. Selection of research priorities for evaluation was based on operational research and program evaluation questions that were identified by 3 or more national malaria control programs and or malaria research institution as key question. But given that we had solicited input from other stakeholders group, we also included operational research and program evaluation topics that were identified by 3 or more stakeholders group and or through the document review. Altogether, 33 operational research and program evaluation topics emerged from the synthesis of inputs from the stakeholder consultation and the document review. Next, please. In the process of evaluating the research questions, we formed an external evaluation committee that was made up by 17 malaria experts from National Malaria Control Program, research institution, and WHO. Thank you very much to all these members, included Elizabeth Juma, who is here, and who played a key role in helping us in identifying the key priorities. And committee members evaluated and scored identified research priorities against a set of defined evaluation criteria, and their scores were used to rank the priorities. Several meetings were held between the committees, and this has led to the identification of research priorities and operational research. Next, please. These priorities included several thematic areas, but for the interest of this audience, we will focus on the priorities that came up in this process and in the field of case management. For case management, 7 research questions were identified, and they were ranked from 3 to 32. In terms of overall regarding the 33 research questions we identified. The first priorities in the field of case management is related to testing and evaluating approaches or interventions to reduce the frequency of stock out and key commodities for malaria case management, especially at community level. We also noted that programs would like to assess factors associated with volunteers, community health worker cadres motivation and retention, and evaluate different approaches or intervention to improve community health workers motivation and retention. There are several topics related to behavioral factors, including assessing structural and behavioral factors associated with delayed care seeking across different population groups and compare different strategies to decrease delay in care seeking. Assessing predictors of adherence and non-adherence to case management treatment guidelines among healthcare providers, and testing and evaluating different strategies to improve adherence to guidelines is a key question for malaria control programs and research institutions. And then testing and evaluating interventions to improve adherence to malaria treatment guidelines and reporting in the private health sectors has been found as a burning issue that need to be addressed for malaria control program. Evaluating different strategies to improve healthcare workers' adherence to IMCI guidelines, as well as testing different approaches for working with incentivizing participation and collaboration of the private sector in the referral, diagnostic, treatment, and reporting of case management is a research topic that programs would like to address. Next, please. So by conducting a document review, called a consultation, and by synthesizing all this information, key takeaway from this prioritization process has arrived, including the fact that the resource priorities reflect persistent challenges faced by national malaria programs in the implementation of core intervention. So, addressing these priorities can help support national malaria program to reach high coverage and improve overall interventions effectiveness. We have also noted that National Malaria Control Program has insufficient evidence on effectiveness and cost effectiveness of specific interventions and intervention packaging, and how to tailor packages for maximum impact and resource efficiency. Many of the research prioritization and priorities spoke to the broader health system issues that are contributing to gaps in malaria intervention coverage. So these issues need really to be addressed if we would like to improve effectiveness and coverage of intervention across Africa. Next slide, please. And then what will happen next? So the INSIDE Consortium will aim to develop a mechanism to track progress against the resource priorities and use of the list to inform future investment in the field of operational research and program evaluation. The consortium will also define a process to regularly review priorities and update the list to reflect progress of new emerging priorities. And we may get back to you during this process in order to update regularly the list of identified priorities. Next slide, please. With that, I would like to thank everyone in this room. The full report from this evaluation priority is available within the INSIDE website, which is posted in this slide. Thank you, Elizabeth. Thank you to the organizers for giving us this opportunity, and I remain available should you have any questions. Many thanks.
For all in any of the presentations, and please, if possible, just say your name briefly and to whom you're directing your question. Yes.
Thanks to all the presenters for presenting. My question is to Professor Roger. There are very many important research priorities that have been identified, and I was expecting to see some aspects about funding for these different research questions. Is it assumed that now that they've been agreed upon at such a level, the funding for these operational research activities would be part of the Global Fund funding applications, or do the programs then need to look for independent funding to answer all these important questions?
Thank you, Jane. We will take a series of questions and then invite the panelists to give their views. So please raise your hand. Okay. Did we forget? Do you have them? Okay. So we will also get you some questions that came from online participants. I think I have a comment for, oh, there's a hand somewhere. Oh, there you go. Fine.
Thank you. This is for the presentation from Nigeria. My question was if there were any efforts to separate Fansidar for IPTP versus Fansidar for treatment when it was found in the pharmacies or in the markets. Thank you.
Okay, my comment is not really a question, but this is for Emmanuel, that quality assured ACT is not equivalent to green leaf. It's not, I mean, if an ACT is not pre-qualified by WHO or did not receive the green mark logo, that does not necessarily mean that they are not quality assured. So the two terms are separate. During AMFM, we used the term quality assured mainly to define ACTs that had been pre-qualified by WHO. But not all ACTs are pre-qualified by WHO. So you might have quality ACTs that are there in the market but have not yet opted for that pre-qualification process. So it doesn't mean that they are not quality products. So that's just a comment, not just for Emmanuel, but also for the room. And we can discuss further. Any other questions?
I have one question from our virtual participants. I'll read it out. Hello, my question is, oh, it's up there. What is the real prevalence of DHA piperquine, and I assume they mean resistance, in African countries, and what would be the real problem with administration to the population? Wait, I got it.
My question is to Stella from Benin. I wanted to find out on the provider adherence. You said a certain percentage, I think said 57% did not, but gave antimalarials. So I wanted to find out in those places where they didn't test, is it that is it because there were no RDTs available, or it was, they just decided to treat without testing? Thank you.
So we'll take Naomi at the back, and then Jane, round two.
Okay, thank you, Elizabeth. So also a question for Benin, for Stella, just like a follow-up. So it's amazing to see private clinics, just 12% of those who are doing the correct thing. So my question is, does the NMCP Benin train private clinics? I know it's not all NMCPs that do that, but just wondering, do they form part of the health providers that are trained? And then the second question I had was for the lack of diagnosis. Was that just RDTs, or did that, I'm assuming that's both RDT and microscopy, but just wanted to clarify that. Thank you.
My second question is on the DTAC trial. Very exciting results and certainly promising alternative. You did mention development of the fixed dose combination. If you could just give an idea of the timelines for that development, how long do you think that will take?
Okay, before I invite the panelists to give their initial responses, Mehul, would you like to pose your question so that the audience can be thinking about it as we take the responses?
Thanks very much, Elizabeth. Actually, one of the key goals for me to come here to this meeting was to actually engage with people who are directly involved in running the programs and to seek feedback. So actually, my question to you is, from the DTAC trial, where I've presented some preliminary results, we're going to get more in the next year or so. We are actually planning a trial with a fixed dose combination, as Jane just mentioned. So my question to you is, what kind of evidence or what more information you would like to see before you consider AAACTs for inclusion in your programs? Or, of course, if you have any other comments on AAACTs in general, those are welcome as well. Thanks a lot.
Thank you, Mehul. Professor Roger, are you ready to give your feedback?
Yes, thank you, Elizabeth. And coming to funding for the identified research priorities, we have in total 33 priorities that were identified. So the mechanism for funding these priorities will depend from country to country and from donors. But now we have a document that can be used for advocacy. And we anticipate that during the next cycle of the funding request, countries can consider some priorities and include them in the request for proposal, as Global Fund is part of this consortium. And we have a framework document that can be used to guide countries in defining and developing these research priorities. The other thing is one funder may not be able to fund all these research priorities, and we anticipate that each of these funders might be interested by taking away some of these research priorities and work closely with NMCPs to define and develop some protocols that can be funded through different mechanisms, including PMI or Bill and Melinda Gates Foundation. Another aspect that we should consider also is that I think these priorities can be used by funders during the request for proposal if they call for grant or for competition across different countries. So now we have a global document that can be used by different funders to guide the mechanism for funding different research priorities. Thank you very much.
So yes, it is very low. And so the question was, does NMCP train private sector? NMCP and their partners, some of their partners are actually targeting the private sector. But the private sector, the issue with private sector is that, some of them are not even recognized by the state. They are not certified, they are not recognized. But when they are recognized, they are not being excluded from training. But of course, I will need to go check the data. I'm guessing that the rate of training, the percentage of facilities or of providers that have been trained is probably much lower than in the public space.
Thank you. Emmanuel?
Okay, thank you very much for the... I think the question I got was if effort to separate FANCIDAF from the, whether it was meant for IPTP or for treatment. Well, you can see that particular variable, we were just, from our objectives, we were just set out to look out for availability and market share. So it didn't establish as to whether it was used for treatment or for IPTP. And the other was a comment by Elizabeth. Thank you very much.
Mehul?
Yeah, so there was a question about the real prevalence of resistance to DP or dihydroartemisinin and piperacin in Africa, and why not administer it to the people in Africa. So I think apart from the partial artemisinin resistance that we already spoke about in Rwanda, Uganda, and the Horn of Africa, I don't think that there have been other reports of partial artemisinin resistance nor of piperacin resistance. Though there were some studies, I believe it was in the Congo, where they saw slightly lower than 90% efficacy of that combination. But really, it doesn't mean that there's resistance. There's a lot more confirmation to be done with that. So yes, I mean, I don't believe there's any reason not to use dihydroartemisinin and piperacin. But at the same time, based on what we're seeing in the modeling, it makes sense to actually introduce AAACTs before resistance is already established. So that's why we were talking about introducing AAACTs as early as possible. But as things are now, and before AAACTs are really available for use for wide deployment, I don't believe there's any reason not to use DP in Africa.
Okay, thank you. You had a second question on estimated time of availability of the combination.
So maybe to just give you a quick update on the timelines of the fixed dose combination of artemether lumefantrine amodiaquin by Fosun Pharma. In fact, they've already developed the adult formulation, and they're now working on a dispersible formulation for use in pediatric populations, obviously. Right now we are planning a trial that will be done using the fixed dose combination, and we're actually seeking advice from the WHO right now on exactly what form and shape that trial needs to take. The goal is also to eventually apply for pre-qualification. We're hoping that if all goes according to plan, by 2025 it will be pre-qualified, but then there's still the matter of procurement and distribution and so on, which will take obviously some time. And also the planning for the deployment, so there's going to be training and so on that will need to be done. So yeah, I mean, I hope that answers your question. Thanks.
Thank you very much. Paul Boateng, I expect you to ask Mehul a question based on that response. Yes, at the back, there is a question. Oh, okay, go ahead first. Thank you. Sorry, I didn't see with the mic.
That's okay. I wanted to ask Stella a question. There were two aspects. One, that sometimes when the test was positive, people didn't prescribe an antimalarial. And then again, why they prescribed an antimalarial when the test was negative. Did you explore that in more depth? Because interestingly, in the hospital, as you said, more patients were treated badly. And we often found when we were trying to introduce RDTs, for example, that people would say, I know what is malaria, so I don't care whether the situation is negative or positive, whether the test is negative or positive. But we had to demonstrate to them that using microscopy that actually the RDTs were correct in their results. So I just wondered if you explored a bit more in depth why people prescribed wrongly. And I wanted to ask from Mahidol, again the question, when would you advise NMEPs in Africa to actually introduce the triple therapy? Because as you said, it's going to take quite a long time, and by then resistance to the partner drugs may have increased. So is there any means of accelerating that so that you can make sure that that resistance doesn't occur?
Thank you. It would be like an observation or a question like to Stella. I hope you said that the supervision which is being done in Benin is always associated with the poor case management. which is an interesting finding, which also agrees with the first observation, which was said that 57% of the untested clients receive the anti-malarials. So I think there should be more things to be uncovered on the association of these supervisions with the poor case management. Otherwise, there is a lot to this. With this also uncovering of the more percentages receiving antimalarials while untreated. Thank you.
Thank you very much, Gladys Tete. And my question is to Professor Roger. Thanks for the presentation. You had mentioned some of your next steps in the prioritization process. And I wonder, does your process include any mapping of already ongoing research in the topic areas? And I wondered what support, if any, you might need from countries or from partners to identify what's already being done in those areas so you can align better. Thanks.
Okay, thank you. So we will take responses to those questions. I'll begin with Mehul. Go ahead.
Yeah, thanks for the question. Actually, that's absolutely critical. It's a very important thing that needs to be decided by all the programs about when to implement AAACTs. So again, not to say that what happened in Southeast Asia will happen in Africa, but if you look back to one of the graphs that I had over there, we started seeing treatment failures increasing around 2013, 2014 to DP, maybe slightly earlier, maybe 1 or 2 years on and off. But at that point, the parasites which were already resistant or partially resistant to artemisinin and resistant to piperacin were already all over the place. They had completely taken over the population. So by the time you start seeing the effects of the resistance in TESs, it might already be too late. So, well, there's two ways to address this. One, which is probably controversial, and you may need to think it through really before implementing it, but to look for molecular markers of resistance. And just based on that, if you start seeing that the molecular markers or the genetic changes are becoming prevalent, then you might want to decide and go ahead and do that. But this is not something that has been done traditionally, and for good reason. I mean, TESs exist and are the gold standard for the good reason, because we want to confirm the phenotype, because, a resistance mutation doesn't necessarily translate into poor efficacy. So, it will take a lot of thinking and debate about how best to implement this. And then secondly, based on the modeling, what it tells us is the earlier you do it, the better. So that means that you can take a preemptive step, and you can decide to start implementing AAACTs even as early as you can, and even as early as possible might be 2026 or 27. So we're already thinking 5 years down the line. So yeah, I mean, I don't think there's an easy answer to it. I think it will need a lot more thought, and it will require a lot of thinking in terms of each individual program, trying to figure out what works best for them. But if you do decide to do it, then the earlier the better, and then you do it as rather you replace ACTs as quickly as possible, and this is what we get from the modeling results. Thanks.
Thank you very much for that response. Before I call upon Stella, sorry, Emmanuel, I meant to ask this maybe for you or for anyone from the Nigerian program. Given these findings, and given that you say the subsidy was stopped by donors, and given that it increased availability and also reduced the prices, this was in 2018. What has happened in the intervening period, and what are the plans going forward, given that you have also informed us that over 60% of malaria case management takes place in the private sector? So that's for you. Stella, maybe you can go ahead.
Yeah, so the question about why were those 16% of positive cases not prescribed anti-malaria. Yeah, I mean, you know, I have to admit that we still need to dig deeper, but I'm guessing that it's probably due to the lack of faith of the provider in the results, because, you know, the ACTs were available. So if really they believe, it might be that they saw other things in that patient that makes them to really, you know, query the results. One thing we did during the study is that we had a health professional in the study team, so they actually redid for all of these patients. They redid the test so that, you know, we could go again and compare that positive case, but that the positivity from the provider's test to the one that we found, which for us is like the gold standard. That's the one we, you know, that's the one we want to take as a correct result, and then see whether indeed, you know, whether there is reason to query that test and so on. So, but, you know, we will dig deeper and try to understand, you know, what is a blessing in all this, that, you know, we are just talking about 16%, although, you know, 16% is a lot, but at least, you know, we have 84% that were appropriately treated when positive. The question of supervision, yes, that is a question also that we are asking ourselves, and I think that we might want to do, we recommended that they do more in-depth study, maybe a qualitative study, to better understand why, you know, supervision is negatively associated. But then I mean, what we are positing is that it's probably due to selective nature of the facilities that are being supervised. Maybe, you know, it's because there is a problem that then they hop supervision or something like that. Yeah, I think that's all.
Professor Roger, if you can hear us, maybe you could respond to the question.
Yes, thank you, Elizabeth. I can hear you. So in terms of tracking process, when you are engaged in this process, it's important to avoid duplicating effort. So this is the main reason that in the process of tracking the progress, we have done an initial crosswork of the inventory of recent operational research and program evaluation studies against the priorities. This is to see what research has been done so far in these areas and where are the gaps. So we aim to build the initial work and develop a mechanism that will allow us to track what additional research efforts are needed to move this agenda forward in terms of the identified research priorities. So we will continue to work with the external evaluation committee. Those are several experts in the field of malaria, and they can provide clear guidance on how to avoid duplication of efforts and how to best
sector to even reporting, because we still do not have a large chunk of reporting from the private sector in our national reporting instance. So we are closely engaging them now to, you know, have them report on the national instance, and also the model being followed is how they can access quality assured ACTs as well as testing for patients that are seeking care in their domain. So those are some of the little efforts that we're putting in, though it's still suboptimal, but the program is, yeah, making some efforts. Thank you.
Yeah.
Thank you very much.
My head of
Nene
branch
wants to add something, but I want to add a question for both of you, which is the idea, the original idea behind the AMFM was to crowd out the poor quality drugs with good quality ACTs. It doesn't look like that happened. If anything, a negative effect was that the non-qualified ACTs lowered their price to be more competitive. So I know there's been a lot of good efforts to improve the regulatory capacity in Nigeria, and I wonder, has there been any efforts to try and get those drugs off the market through stick approaches rather than carrot approaches? So.
Okay, thank you. So maybe I would also add that one of the key things that we're also doing to this effect is pushing for pre-qualification, getting that final bit. I know that we've, gone through a whole lot of stages, in the pre-qualification for in-country manufacturers, so that would, I mean, that's eventually what would, bring everything to a, to a stop, so that's what we're really, pushing at, and we're hoping that very soon we'll have 1 or 2, 3 in-country companies, manufacturers pre-qualified, getting their full pre-qualification, WHO.
Okay, Peter has a comment.
Yeah, thank you. I have a comment. I think I should make a comment. And I think, of course, one of the main biological threats we have in terms of case management is resistance. And the question is not if, it is when. And so what we're actually trying to do is to be ahead of the game. And like Pascal presented yesterday, there is the strategy that is being put together for the African region. And so WHO supports innovation, both in terms of new molecules for treatment of malaria. I'm looking at MV, and also innovation in using existing molecules in better ways, as it were, as a way of tackling the whole issue around drug resistance. Of course, that's the whole concept of combination therapy. We're using more than one medicine's different mode of action would indeed reduce the probability of development of resistance to each of those molecules. So it stands to reason that the more molecules you have combined, the more you increase that probability. However, you are balancing this against adverse reactions, what is feasible, what can be combined. So in that context, I think the whole idea around triple therapy and all is something that we're looking at with keen interest. And because the reason I'm making this comment is that several questions have been coming. How soon should countries start? When should they start? And things like that. But I guess at the end, there is a process. First and foremost is, from a WHO perspective, getting these things into guidelines when we get to that stage. And I think the question really that we are asked, or from a programmatic perspective, that countries should be asking, or we are asking countries, or trying to find out, is what is the appetite for changing, because you don't know the cost of these medicines, so that becomes an issue. So what's the appetite for changing a working combination for something else, which has the probability of delaying resistance, while what you are using is still efficacious. But that other one might have the potential of being more expensive. That really is the question. Because right now, when it comes to changing, of course, there are countries that have eliminated malaria and all of that using what is currently available, even dealing with the whole issue of resistance and all of that with what is available. But projecting and looking forward, what are we willing, as a malaria community, so to say, to invest in delaying onset of resistance, even if it means that you're going to pay more to get something in place of what is apparently still working? Because we recommend a change of what you're using when your TES begins to show failures. But here we're coming with another concept of no, from modeling and all, we know more molecules might prolong the development of resistance and things like that. And of course, when you begin to retool and bring together molecules already in use, in theory, you are also reducing the number of combinations available. Because once you go AL, AQ, AS, so But all of these are things that need to be considered. But we would not get to this kind of discussion except we have studies like this ongoing. And so we need, and it's something that we need to begin to think ahead. And when Barry is asking countries, what would it take? I guess that's the question he's asking. I'm putting it that way. If you are using AL now, and your efficacy is giving you 95%, what will it take to make you change that to a product that may be a little bit more expensive, but you are gaining on, potentially, prolonging the therapeutic useful life of the medicines while awaiting new formulations, new molecules, and all. So I guess that is the discussion going on. But you cannot have that discussion except first and foremost to show that your combination is working and it is safe. Then we have that discussion. So I just wanted to frame and put it in that way. And that, yes, we support innovation, but at the end of the day, when all the studies are done, we're still going to have to go through the rigorous process of guideline and all of that. But it's great for countries to begin to think of this and begin to think, change the way we think towards the whole issue around drug resistance. And as we come up with the strategy for containing drug resistance in Africa and all of that, we might need to do things differently. And the thinking and all might need to change. So I just wanted to put that in context of what we are discussing. Thank you.
And who will convince the donors?
Okay.
That was actually going to be my comment, and I really appreciate the discussion, and it's so important. There are so many moving pieces, but like when I think about it, it's not just what would it take, but like what are we going to give? So if your resource envelope is the same and you want to buy a more expensive drug, then something else has to be cut. And I know we've all been talking about like the supply chain challenges and why are we not paying for training and all of these things, and it's all the same envelope, I guess is what I'm saying.
I don't disagree with you, but I think we also need to begin to look beyond that. We all want to, we say we have a target to eliminate malaria by 2030. Then we sometimes need to speak a different language. We're so used to planning based on what is available, not what is needed today. And that is a challenge in the malaria community. I remember, I said this, I was sharing with someone not long ago.
Peter, I'll give you 2 minutes.
2 minutes, yes. Comment. Just 2 minutes, I would end with this.
You're holding up coffee.
Okay, sorry.
I
just want to share an example. In 2004, in 2001, we shifted to ACTs from chloroquine and SP. And by 2004, we had only about 3 countries using ACTs in Africa. The Global Fund was still funding chloroquine and SP. And the issue was, oh, there was no money to pay for this. Who will pay for it? We are moving gradually. Then there was an article that was released that malpractice. Why are we buying what have you drugs for African countries? I remember we were called to a meeting Saturday and Sunday. I was at that meeting. When Global Fund, we reprogrammed all the chloroquine and SP to ACTs, same quantity. Where did the money come from?
Yeah. Thank you very much, Peter.
But chloroquine is failing, AL is not. Yeah.
Okay. Thank you very much. I would like to bring this session to an end. And one last thing, Mehul, what I was asking the Ghana program to ask, but maybe they are shy to ask. Many countries that had ASAQ as first line and AL as alternate first line or second line, what ended up happening is because of preference, the use of AL increased while the use of ASAQ decreased. And the primary reason was not efficacy. It was side effects by people who can shout and complain. And that has been a problem. When we develop these products, let's also think about acceptability by the target user. Everything may be right from the modeling, the science, and everything. But if the intended user will not use it, then we are not working. I would say that we need to consult with the target users as well and see what is preferable rather than combine and then say, now again it contains a drug for which compliance might be an issue. So with that, I would like to thank all the panelists. Let's give them a round of applause. And also Professor Roger Tin, thank you very much for joining us online. We appreciate your presence and for agreeing to make this presentation. Thank you very much for that. Our next session will begin at 4:30, so we will take a break and come back and discuss the monitoring global progress in malaria case management. Thank you very much.
Molly, Patrick, and Noor, are you on the line? Can you hear us? Molly, Patrick, Noor, are you on the line? Can you hear us?
Hi, I'm here. Can you hear me?
Yes.
This is
Hello, Molly. Noor, Patrick, are you on the line? Let's see. Noor and Patrick, you may
Larry,
have...
can you hear me? This is Constantina.
Yes.
Could you please ask Jules to
They
give
already have.
panelist
They've already
rights
been
to
elevated.
Patrick, please?
They've already been elevated.
Also Patrick. Okay, thanks.
Yeah. Noor and Patrick, you may have to accept the elevation to panelist. Can you hear us, Patrick, Noor? Trying again, Patrick, Noor, if you hear us.
I do hear you, and I have been elevated.
Great, great. Welcome, Patrick. Noor, are you also on the line? Noor, you need to accept the invitation, and then it will be elevated to panelists. Okay? Noor, can you hear us? Noor, can you say something? Anything?
Larry, Noor is not connected.
He's not, okay. He was connected earlier, but maybe he was having trouble and had to drop off. All right, well, I think we can start. So, all right, well, let me invite Dr. Peter Olamesi to the dais to chair this session.
Okay, thank you very much, and good afternoon, everyone. Hope your coffee break was nice, and you are awake. You didn't answer me. Are you awake? Some are, some are not. Okay, so we're taking off on this section, and we want to make it as interactive as possible. And I will want to invite Elizabeth to please join Larry up. We'll be having several presentations remotely, and at the end of those presentations, would want to hear from countries. And so I'm saying this up front so that you begin to get ready as countries. We want to know, because here we're looking at monitoring global progress in malaria case management. What are you monitoring? What are the challenges you have? What do you think we should be monitoring? So it's an opportunity to hear from countries. And so without wasting any more time, I would invite Larry to sort of give us a broad introduction to this. Thank you.
Thank you, Peter. So this is actually something that Elizabeth and I, with others, have been thinking about and working on for a couple of years. And I think it should be no surprise to anybody who's working in case management that at the global level, there's a lot of focus on indicators around vector control and preventive activities. You know, you often hear the number of people covered with ITNs, the number of people covered with SMC, but case management indicators often are left off. And so, oh wait, I'm doing this again. So, there are reasons for that, and particularly there are challenges with the indicators we currently have. So, our indicators for case management fall into sort of two big categories: facility-based case management indicators and indicators that we get from national household surveys, MIS, DHS. And they each have their unique set of problems. The facility-based case management indicators often are not consistently collected between countries and even sometimes within countries. What the definitions are sometimes obscure, and there's really no consistency, so you often can't compare between countries and between one country and another, or even over time in the same country. For the MIS DHS indicators, it's a different set of problems that centers largely around how we define a malaria case. And anybody who knows DHS or MIS surveys we don't look at children with malaria treated, we look at children with fever treated. And increasingly, as malaria is controlled, I mean, my colleague from Senegal here would tell you that most fevers are not malaria anymore. They used to be, but they're not. And so it's a very problematic indicator to say the percentage of children with fever who get treated with an ACT, because in an elimination setting, that number will actually go down because fewer and fewer and fewer of those fever cases are malaria and should be treated with an ACT. Last year, Elizabeth and I, along with colleagues, proposed that we should undertake a critical review of an evaluation of the potential of the current global malaria indicators to really assess their ongoing utility and also needs for potentially additional indicators or better definitions of existing indicators or refinement of current indicators. And just give you a couple of examples of sort of what we're talking about in terms of indicators. So this is one of the indicators that we collect from a malaria indicator survey, the proportion of children under 5 years old with fever in the last 2 weeks who had a finger or heel stick. Again, there are a couple of problems here. One, it's focusing on fever as opposed to, suspected malaria cases. And two, they could have had a finger or heel stick for testing of anemia or for other blood testing. It doesn't necessarily mean that they were tested for malaria, but the indicator is often interpreted as the percentage of children with suspected malaria who are tested for malaria, and it's not that. Similarly, here's an HMIS indicator from the WHO Malaria Surveillance Manual. Proportion of all malaria treatment of febrile children aged less than 5 that was an ACT or other. And again, the challenge here is the ambiguity of the definition. Are you defining malaria cases as just those that are confirmed or those that are reported, which may include clinical cases? I think our feeling is that it's worth conducting a review of these cases. fortunately, we have an opportunity with the support from PMI. We are planning to bring on a consultant in the near future that will help lead this critical review. We have, Elizabeth and I, over the last year, have reached out to the folks on the line here, WHO, the monitoring or the surveillance monitoring and evaluation reference group, and other key partners to get agreement on a way forward to do this critical review. And I think we have good consensus on moving forward. And as Peter mentioned, we're going to let our panelists speak for a little bit, but then we're going to the people on the panel, and whether virtual or in person, are going to sit and listen, because we want to hear from the programs, how are you using your the case management indicators? Are you able to make decisions based on the indicators you have? What gaps in those indicators do you have, and what challenges you had with the indicators that you're tracking? So I think with that, I will hand it back to Peter, and for the rest of the.
Thank you very much, Larry. Thank you for that brief overview, and as it were, laying out what the current challenges and things we want to speak around. So we would move on. I don't know if, no, is he online now? He is. Okay, thanks. No, over to you. Hello.
Thank you, Peter.
Yeah, we hear you loud and clear.
I'm told, yes, thank you. I'm told I cannot show the video because the host has stopped it. Maybe there's really not much interest to see my face.
No, we want to see your face,
Yeah,
but
we'd love to see your
unfortunately,
face, Nor.
we combined all the bandwidth in this room, yet it was not enough to carry your face.
See my face. I'm sorry, I will disappoint everyone, but I'm happy to show up if I can be allowed to start my video. And the host can give me access to video.
We'll try.
Should I just carry on?
Yeah, maybe you start while we try, because I think the challenge we might have is the bandwidth.
Yeah, I actually don't have a lot to say, just to thank everyone for organizing this and for asking me to join. Like many other areas of malaria, the case management indicators have their inherent challenges. And very often these challenges, the easier part of the challenge is actually when it is related to definitions and resolutions of ambiguities. The more difficult part of the indicators in terms of their reliability is the systemic issues related to measuring them effectively. We have issues around case definitions. We have issues around the availability of diagnostics and how that influences case definitions and how do you track that. The issues around the health worker practices and belief in diagnostics and how that influences those case definitions, and how those then eventually influence the quality of the indicator. We are currently trying to update the surveillance monitoring and evaluation reference manual, and we'll be revisiting indicators across all areas. We are looking forward to the outcome of this meeting, and very much looking forward in particular to hearing from countries. Mine is just to say, when you're thinking about indicators, don't just limit yourself to the numerator and denominator, but also focus on the systems related issues that determine whether that's a viable indicator or not. Over to you, Peter.
Okay, thank you very much, and I think you've hit the nail right on his head, and you've given us the matching order as to what the discussions and the areas we should be focusing on as we listen to countries. So We'll go right on to Molly. Are you online?
Hi, I'm here.
Please,
Thank you.
the floor is yours.
Great. Thank you so much. Yeah, I guess I would just really echo what Noor just said. Really hearing from, as Larry was saying, hearing from everybody about how these are used and how they want to be used will be really key to understanding what other types of information are needed to round out the picture. So if you're seeing problems in suspected tested, is it, what are the types of decisions that you want to make around that? And then find out whether you need to look at stock, whether you need to look at provider behavior, what are the other pieces that you need to look at. Just to say too that I think also coming up with indicators is not the hardest thing. Coming up with the methodologies to get the indicators at the granularity that you need is the hard thing. So really trying to understand what kinds of, not only the indicators themselves, but what kind of methodologies we could use to get that information at a granular level, because oftentimes that level, and it's a little bit easier with these case management indicators if we have a good health facility information system. But it's often at that level that the problems need to be solved. And I guess I would just add that as well, that really thinking about all the different indicators that need to be looked at and analyzed to be able to solve an issue, because the measurement itself isn't going to solve the issue, but it will give us an idea of where to go and where we can sort of focus investigative attention on how to solve an issue. If there's an issue in the case management cascade, what are the reasons behind it? So I think I would just emphasize that along with all of the indicators themselves and precise definitions, that we really think about the methodologies and the granularity that's possible.
Thank you very much. I think you raise very important points and very important issues, and I hope countries will take note of this, because like I said earlier on, it will be great to hear from you, the case management focal points. And so I would move on now to the next panelists. Patrick?
Very good. Can you hear me well?
Yes, we can hear you, and we were seeing you a short while ago. Even no, we can see you now.
Very good. Well, excellent. I wish I were able to see you in person. I hope you enjoyed your field visit. I don't know if it's helpful if I could share my screen for a second. I've been working with the Clinton Health Access Initiative over the last year to focus a little bit of attention on a model of effective coverage that'll be familiar to so many of you who work in case management. I don't know if, are you seeing my screen now? This should resonate with a lot of you, that of all the people who are infected with malaria, there's a fraction of them who are symptomatic and a fraction who are not symptomatic. And of those who are symptomatic, there's a fraction who seek treatment and a fraction who don't seek treatment. Of those who come to a health facility or community health work test, and that cascades down through these different layers. And of those who test positive, there's a certain proportion who receive the policy recommended treatment. And then of those, a certain proportion who actually adhere to that treatment and are finally cured. And this cascade has been shown many times, but it often results in a highly efficacious treatment really reaching only a small fraction of people who can benefit from it. And as we were thinking about this cascade, we, like others, have identified that it can be a useful way for identifying where there are problems with the case management system and where to make changes. But it also can be challenging because you can divide this into many, many steps, which may be impractical to develop indicators for each step. So we have been thinking primarily about focusing on maybe 3 areas where bottlenecks occur. One in terms of accessing appropriate sources of care or sources of care where the recommended diagnostic and treatment commodities are available. The second bottleneck focusing on the quality of care that's delivered at that point. And then the third bottleneck focusing on the treatment and the patient or family's ability to completely adhere to that treatment. And so I think I am really enthusiastic about this initiative to revisit the case management indicators. And I think we'd humbly like to suggest as we think through it, whether we could identify key indicators that would help guide programs to understanding whether they need to improve the community's ability to recognize and access care, whether they should invest more resources in improving the quality of care once people reach it, or whether there are changes, often when there are changes in a first-line treatment that requires a different dosing regimen, or that requires, or we've added something like low-dose primaquine or primaquine or tafenoquine for radical cure, there are implications for people's ability to complete that treatment. So I, on behalf of my colleagues at CHI, just wanted to share the cascade model again that we've been working with, and really look forward to hearing from all of you about how feasible it might be to look at case management indicators that are positioned at several steps along that pathway. Thank you.
Framework might be a good framework. It might be a good framework to look at the existing indicators, to look which questions they're answering along that continuum, and then that will help us to identify where the gaps are as well. So those are Elizabeth's words, not mine. No.
Thank you for speaking, anyway. For hearing a male Elizabeth voice. So. Yeah, so
anyway, can we turn the lights up?
Yeah. Can we have the lights, please? I just want to be clear. We're not trying here this evening to develop indicators, okay? But we're trying to, as it were, contribute to the process and ask ourselves, are we actually capturing the right indicators? Because here you are case management, are we capturing the right indicators? Are there things we should be? What do you need? Let me put it this way. What do you need to enhance your programming when it comes to case management? Because indicators should be useful to you from a programmatic perspective, not just reporting. And it would be good to hear from countries and the voices of countries. And I know that at an earlier stage where we're trying to get countries to begin to scale up diagnostics. Of course, then we're trying to monitor what percentage of patients that come in with suspected malaria get a rapid diagnostic test or microscopy. There are some countries where that is, at least in the public facilities, is gone way high up. Is that still an indicator that you want to pursue if in your public facilities almost everyone who comes in, except if there are stockouts, would have a diagnostic test. So in essence, what I'm saying is that the usefulness from a programmatic perspective over time of indicators will change. And if that is the situation, we really need to begin to know and dialogue and to see how and we move forward on this. So having said that, and indeed using the framework that Patrick showed, which is classic. Who wants to go first? Okay, maybe I ask a question. Let me put a question this way. At national level, how much of case management is directly influenced by the program? Is it? So how much of, yes, you determine the drug, you determine diagnosis must be done, but at the end of the day, is it more with the clinical service delivery or a program issue? How much of an influence do you have as programs when it comes to delivery of case management? And then that may help us to begin to discuss what sort of indicators we should be measuring if you need to change practice. Still waiting. Okay, yes. Now, seeing hands. Thank you.
Yeah, thank you so much. I'm Anita Kamara, NMCP Sierra Leone program. Yes, it's a very important, this is a very important session. There's an indicator that we are still battling with, which says proportion of presumed and confirmed malaria cases. For long, we have introduced the test, treat, and track strategy. We have been using it. And we have changed our policy since 2004 that we should test before you treat. So having said that, are we not encouraging people not to follow our policy, our treatment guidelines policy, by test before you treat? Because if we are still encouraging them to, have presumed cases vis-a-vis based on knowledge of the service provider or the medical doctor, that when the patient comes, if there are no RDs or whatever, you just treat based on signs and symptoms. But are we not encouraging them? Because it's a long time now, we are still on this indicator. And when we look at our result, the result of this indicator is very minimal. The presume and confirm. So even at our program level, sometimes we confuse. I said, what is this presume? What is confirm? It's confusing because it's blended together. We have cases presume and confirm as one indicator. It's confusing at times, even at our own program level. I think we need to throw light on that because for long, we need to promote our policy, whatever we are saying. We need to preach what we are saying. We have given the people a leeway for a very long time. By now, they should be used to our policy now. Okay, that's what I want to say.
Thank you very much. Oh, yes, Nena, Nigeria.
So thank you. And thank you to the presenters, and even more thanks to my colleague that just started it. We're just discussing it. That presumed, or what is it now? Suspected malaria, case is really very confusing. And I think that indicator was way back then when the policy was, treat, what was it now? Kind of aggressive treatment or something of cases. But now we're kind of narrowing down on what we want. And it is very clear that you must test all fever cases. So I'm also like joining my voice to say, that indicator, it's really not necessary, and it's not speaking to what we have. That's not to say that definitely diagnosis, be more specific on numbers, that numbers that were diagnosed or cases that were diagnosed to be positive, you know, as against numbers of fevers seen. Okay, we don't want to mess with that, because that is the mainstay, and of course the treatment. But then, based on what has been, you know, put across, we need to start thinking of quality of care, because quality of care now is a pointer to how well we're doing in terms of the classical guideline that we have. And I don't think that what we're saying now on malaria, it's going to ever change. It's not going to ever change. It remains like that, because we're saying now all fevers must be treated. So it's important that we bring in quality of care, because this will be an indicator for us to use to measure, you know, how much and, you know, how far or when we can assess ourselves, or when we can say we're there, you know, or how long or how much more intervention we will push in to make sure that we are, you know, we're getting to what the guideline speaks to. You know, I hope I've been able to make some reasonable. Thank you.
Yeah, thank you very much. I would come back on that, and I just want to throw it out there, because you raised a very broad quality of care. What exactly, in that broad spectrum of quality of care, what sort of indicators, what are you referring to? What do you want us to measure?
So for now, I may be a little bit blank on that, but just to say that, you know, quality of care, can we put it, you know, just close to what we're saying? How many people were tested in terms of doing the quality, test, which we know that it's either microscopy, and we know that for microscopy, you have to go a lot more mile on the quality of microscopy, you know. So, and also, of course, MRDT, which is easier, it has to be quality assured, you know, when once it's quality assured, and of course, with the other attributes in terms of storage and all that, that's okay. But then for microscopy, you know, how much of quality of that microscopy, because we know that it's not just, while microscopy is the mainstay, you know, it has to be, what is it now? A microscopist that has been trained, a trained microscopist, yes. You know, so when we're talking about that, so in terms of quality of care, we want to know, we want to make sure that people are really tested, you know, before, you know, treatment is given. And in terms of treatment, it has to also be, you know, quality assured ACTs. And like we're saying, quality assured, yes, in terms country specific, and of course globally, something like that. So, but this is, like I said, I really don't know, but quality of care is something we have to, you know, pay more attention to in terms of regards all this. Anyway, I don't know, but I think my colleague wants to say something.
Well, okay, Dr. Emmanuel from the NMEP in Nigeria. So just in addition to what she has said in terms of quality of care, for example, we are currently trying to see how we can fully deploy that. We have a standard and guideline on it, and it measures the structure, the process, and the outcome. So of course, in terms of the structure, the motivated workforce and knowledgeable workforce is one of those things that we are measuring. Then the infrastructures. Then in terms of the process, the quality assured ACTs and then the RDTs is part of this. Then the outcome, the client satisfaction is part of it. Thank you.
Okay, thank you. Looking out for hands. Yes, this.
Thank you. Dr. Mabre from Rwanda. Maybe starting from central level, we have a control on designing clear guideline, defining who should be tested. If we have a fever, you should test everyone. at all levels, either community level, health facility level. This is one. And also we indicate which kind of test to be used. This is our mandate. But also we make sure that we train people, lab technicians, nurses, medical doctors. And we even go beyond and train them on how to manage simple malaria, severe cases, etc. But for us, we also supply commodities to make sure that they have all what they need. They have clear registers and tools. And the feedback we get from them is through our reporting system. We have clear M&A framework, either through our national guidelines, also through our national strategic plan. A typical example is here we say we need to monitor the proportion of suspected malaria cases that receive a test at the public sector and health facility level. At least we need to measure if people are complying with the national guidelines. And sometimes we say you are happy because it's 100%. But when you go at a field level to see the quality, sometimes we are surprised to see that probably some case of fevers were not tested as recommended. Sometimes people may prescribe a wrong first-line treatment. Even some people may use rapid tests at health center while the recommendation is using microscope. I think it's where we can detect some issues, and waiting at central level, we may miss some good point. I was giving just one example, but we have many of them. And maybe we need to go beyond the reporting system and organize kind of health facility surveys to see the quality of service. What is the early treatment? Is it within 24 hours at community level or at health center level? I think through that kind of further analysis or surveys, we can detect how we can provide additional input, either for the quality control, but also mentoring people to ensure that they comply with the national guidelines. I think these are my few comments, but regarding severe case management, this is very tricky because when you conduct death audit, we can detect many gaps. We have trained people on time how to transfer a case from the community to the health center. There is a clear job aid. But sometimes we can see that community health workers are transferring cases which are not the real severe cases. And from there we can say there is a gap. But from health center to the hospital level, we can see that nurses are transferring cases without pre-transfer treatment. And this may lead to complication. Without conducting that kind of details, supervision, I think you may have a disconnection between the guidelines and the implementation, and I think we need to see how to link those two things. Thank you.
Thank you. Yes, please go ahead.
Thank you very much. I'm Dr. Omar from Kenya National Malaria Program. Mine is to take back to the point which Peter asked. What is the point of care? Because at the national level, actually, yes, we might do quantification, we might ensure that facilities are getting drugs, RDTs and all that, and capacity building is being done and all that. However, it's not us actually who implement the day-to-day management of patients. But in terms of the stockouts, in terms of the indicators, I wanted to bring out the issue of stockouts. Previously, for stockouts, we used to use a survey to go out maybe once every twice a year or something and see over the last 3 months this facility, how often have you had a 7-day consecutive stock out. So I think we need to redefine and look at how best can we get an indicator for stock out, because currently we are in Kenya, for commodities, we have been able to have the commodity dashboard on our KHIS. However, for the facilities to report in a live manner stockouts, such that can be known and a prompt action can be taken, because all those things can be done. A patient can have because of very good sensitization, you can have a patients seeking health care very fast. The health provider might be very good and be tested well, and but if the drugs are not there, then there's nothing which can be done. So that's an issue that I think needs to be tracked, and because most of the donors don't want to hear about surveys. So how do we routinely put this thing in place? Thank you. And also, just to add what one of the Rwandan head of malaria program mentioned, fever on its own is not enough. As we experienced during the COVID era, it was mentioned that anybody who has fever should stay at home or call a certain number, assuming that it's COVID. So many of our malaria patients were stigmatized. So fever plus what clusters of symptoms or signs should we now go? For malaria, we should now go beyond fever and a cluster of symptoms and signs. Like in TB, you know that if you have a cough that is more than 2 weeks, fever at night or something like this, I think we need to have a renewed definition of what suspected malaria is. Thank you.
Sorry? Good number. I'm seeing all the hands. There's okay, Dennis.
Thanks very much. I think in addition to what Kenya has said, most of the indicators, they say fevers, but they are, and then they test. But I think there are many cases of malaria which don't present with fever. So I think we should only say suspected malaria, then test and treat. And he talked of stocks. Like in our documents previously, I think stock out for more than a week. But for malaria, if there is a stock out of 1 day or 2 days, patient will die. It is not like TB or HIV. Even our country, particularly as a program, we have adopted that any stock out of 1 day is a stock out. I don't know whether other countries it's already like that. We just decided. Then, as Peter said, there are many stakeholders particularly in logistic supply. Like we have control, but may not be 100%. Like our national medical stores, we may advise, and some of the stockouts may be because of that entity. How can we put an indicator to know that really the every month supply is delivered, so that also we monitor the logistics? Thank you.
Thank you very much. Wusi Kwamainza from Zambia. Indeed, a very important and timely discussion. So I'm sort of just reflecting on some of the challenges that we have. For example, fever, fever diagnosed with either malaria diagnosed with RDT and or microscopy. So we still have those kind of indicators. So what does that actually mean? So, those are candidates, I think, for, for us to really consider thinking about removing, then it's also this issue around definitions. I think there's a bit of confusion. I'll give you an example. We confirmed malaria case. We had some interaction where, a confirmed malaria case, according to this particular service provider, was that I have confirmed that this case is either positive or negative. So already that breeds a lot of confusion. Even, indicators around a patient, how many patients received an antimalarial. What does that actually mean? So those need to certainly be looked into. The issues around referrals. Yes, we'll record, community health worker referred. But do we actually track on the other end how many of those referrals were received and what the outcome was? I ask this because in most cases you find, when patients are referred in a severe condition at a higher tier health facility, and then we lose that particular patient, the first question that individuals will say, no, this patient was referred from this facility. But where did this facility, from where? So you need to sort of drill down and try and find out if there are issues that are happening with that particular health facility and also sort of assist them to improve their service delivery. The other one I think we should also think about is test positivity. We have an experience where, particularly when malaria is going down, and the competencies of the clinicians providing the service, when they clerk their patients, and I think my colleagues referred to this, look at their algorithms, most likely you will find that the individual that they send for a test, when that test result comes out, it's actually positive because they've done due diligence, they've got the capacity, and then you'll find that in this particular area, even if malaria is low, test positivity is 100%. And then this is reported that, everybody has malaria in this particular health facility, but it is because of those things. So I just wanted to also appreciate the submission from our panelists, and just to highlight what Patrick raised. This issue around access to care, service quality, and adherence to treatment, I think really summarizes the key issues that we have around case management. When you look at access to care, our colleagues talked about, most of us in our strategic plans, we say, no, within 24 hours of onset of symptoms, you must be diagnosed and treated. But how do we actually measure that? The quality of care is linked to availability of, the various tools, the RDTs, the drugs, everything that makes a clinician or a service provider be able to provide the quality of care for that individual. How do we actually measure that these things are actually available? And once our patient is treated and provided with the treatments, they will leave. The follow-up process is not well documented. What's the outcome of that particular patient once they have received this particular treatment? So just to agree that there's a lot of work that needs to be done, and I'm happy the chair indicated that we're not solving these problems in 2 hours this afternoon. But just to put it on record that it is a very important issue and certainly needs our kind consideration. Thank you.
Okay, I think he's mentioned quite a number of the things I wanted to say, but I'll still add some of the indicators I would like to see, particularly with severe malaria, are one, about triaging. How well are we triaging our patients? And then two, there's nothing now about the kind of anti-malarial given. I mean, it may be recorded in the patient's folder, but are we able to capture that? Was injection artesunate given? What was the duration of the injection artesunate before it was switched to oral ACTs? I think it's something I would like to know. And then the quality of our monitoring, okay, basic vital signs, okay, are we monitoring all those? And then he mentioned the follow-up care, whether it's being also documented. And then also the quality of the documentation by clinicians. Most of the time you realize that if you follow up on patient folders, the documentations are so poor and so very scanty. And so you might not be able to get a lot out of it. And so we should be able to also track that. And then some of the time factors as well. How long did the patient take to arrive at the health facility from arrival to being seen by a clinician, what was the time, and then all that. So all those delays, I would also like to see in our indicators. It may be it may be a lot for routine data collection, but maybe we should look at regular surveys to be able to track some of these things. Thank you.
Okay, thank you very much. Yep. Okay.
Sorry, but I will go in French. En revenant aux différentes questions que le président de séance a posées, moi, il me revient à l'esprit comment est-ce que nous faisons pour capter le traitement de relais du paludisme grave. Parce que plusieurs patients font des paludismes graves, reçoivent le traitement injectable. Plusieurs fois, ils sortent, même avec l'ordonnance pour le traitement de relais, qu'ils ne vont pas prendre et souvent font des rechutes. Est-ce qu'il ne faudrait pas un indicateur pour capter le traitement de relais dans le cadre de la prise en charge du paludisme grave? C'est ça ma préoccupation, parce que comme je disais, beaucoup de cas de paludisme grave ne sont pas traités complètement et ces patients-là font des rechutes. Donc, pour moi, il me semblerait opportun peut-être de penser à un indicateur permettant de capter le traitement de relais dans le paludisme grave. Merci.
Okay, thank you very much. I don't see any hand right now, but we can, okay, yes, please.
Thanks. One of the things I wanted to mention that I've been bugging Larry about for at least a year is the whole question around case management of malaria and pregnancy, because right now we really don't have any visibility into it. Like, I'm only aware of 2 countries that actually disaggregate the cases by pregnancy status. So we don't know how many cases of malaria and pregnancy there are. We don't know how they're being treated. And I know there's a lot of talk that the first trimester treatment policy is probably going to change fairly soon, which will, I think, simplify everyone's life. But even in the interim, we're not sure that pregnant women are getting the drugs they need. And I think particularly as we move towards elimination, we're going to see cases of malaria and pregnancy presenting in a more severe way. And we really need to be aware of what we're looking at and figure out how we can best track and serve those cases of malaria and pregnancy, which is not something I think we're prepared to do right now. So I did want to throw that out there. I also just wanted to mention around the quality question, I think there are a couple of other things that I've been thinking about in terms of what I think about when I think of quality for case management. One is like, is there actually a physical exam? Because a lot of times patients come in and they get a test, you know, they have a fever, they get a test, but are they really getting a physical exam? Are they really being screened for all of the signs of severe malaria? And it sounds like some places, but not everywhere is doing that well and uniformly. And I'm also hearing that there are some patient flow issues in places. So someone might come into the OPD and be referred for a test, but they might end up with a prescription before the test result is back. Or they end up just waiting in 3 different lines and they spend the entire day there. And I know somebody mentioned client satisfaction, and I'm imagining I would not be super happy if I had to wait in 3 different lines to be seen, to get tested, to get a prescription, to pick up my drugs. So just thinking about some of these other issues, I know those are difficult indicators to collect in like an HMIS format, but when we think about how we want to support case management programs, I think there are some other questions that we can maybe start thinking more about in terms of addressing the quality issue.
Okay, thank you very much. I would, yep, of course, it's open. You're raising issues, so you're not necessarily asking for answers to those issues you're raising. So as many issues as we can raise, and so please go ahead.
Yeah, mine is, I think, observation or suggestion or recommendation. I don't know how to put it, but I'm happy that we are going to revise those difficult indicators that are hard to track. But I don't know if other countries have time to revise the indicators and have a chance to add some of the indicators that can be actually easy to track. I know my colleagues at Malaria Division, sometimes they give us sleepless nights to make sure that when it's time to revise the indicators and to add some of additional indicators, as long as you justify those indicators, we have that opportunity to add those indicators that can actually help to track how you're doing at the facility level. So maybe if that is something that we can do as we wait for the revision of those indicators, something that we can try. The other thing is to also look at the systems. Do the existing system talk to each other? And this includes supply chain systems. So if there's a risk, if a community health worker reports a risk of stock out, how do we make sure that there's a resupply of commodities? So that is something that we have to look at and see if those health information management systems talk to each other and we don't miss any information. And also try to get out of the normal routine and try to innovate and see how we can monitor our indicators that are and our services. Especially someone mentioned quality. I think everyone talked about it. It's something now we have to look at. Yeah, thank you.
Okay, thank you very much. Before I go to the panelists, I just want to try to, in very broad terms, summarize what I have been hearing. Yeah, we'll take more. I think there are, because what we're planning to look at were current global indicators. And people have spoken mostly to things that affect their day-to-day practice and delivery, which are not directly linked to the global indicators. Because most of the issues that have been raised there are not things that are captured in the global indicators, but important for you. So you are raising issues around case management that you need to be able to track and respond to at country level. That's most of what's had here. And if anything, that some of the global indicators are hard to track, and you're actually wondering, why are we still collecting them? Because it's not particularly of importance to you. But I guess we also need to ask ourselves, is it important to keep collecting these at a global perspective, which is a bit different from what, in addition to what you need for the, you see, a lot of what has been brought up here, it might be difficult to have specific indicators for them. But you're talking about systemic surveys to understand what is going on and what the issues are and how they can be addressed. Some of those things might not even make it into your national database. But there are things that you need to do and know. When you talk about diagnostics, how long it takes, how long people stay, do people follow when you refer, do they get to the referral point and all of that? Those are important things for quality of care. But those are not things you would capture on a routine database and for indicators, but things important for case management. So I'm just trying to put those two buckets. Though we started out here with global indicators, you've raised a lot of things which are outside the parameter of the global indicators, but important, that would enable you deliver and even make a dent on those global indicators. There was another hand up there, and then I would come to the panel.
Yeah, thank you, Peter. Maybe to add on it. Yes. I'm Dr. Abdallah Rusasi from Tanzania. I think most of the party, you make a clarification, but our issue in Tanzania mostly is data. Yes, the indicator, but the data is an issue, quality data. If you go to the ground level and make a triangulation, between the register, you will see very big discrepancies. So one issue is data to us. The second issue, for instance, the confirmed cases visas dispensing ratio, the area where my colleague has been talked about, is a big issue in Tanzania. The ratio is an issue in such a way, it seems that most of the medicine is maybe stolen or somewhere taken illegally. But the confirmed issues, again, it comes with the challenge of the quality of services. For instance, the confirmed issue is inside. If you unpack it, you will see the MRLT and the malaria microscope. Again, we have the challenge in the quality of malaria microscope. We are saying microscope is a gold standard, but if you go to the ground again, seeing what they are doing, no quality GIMSA, no trained, qualified lab personnel. The microscope is very old, no service. So again, these confirmed cases has a problem inside. Thank you for that.
Yeah, thank you very much. And just going by that example, and I think it highlights the point I was trying to make. The training, the competence of the microscopist, of the health worker is important. But that's a different mechanism of dealing with that. Your indicators would not, it's how do you use indicators to capture that or data? Larry, I think you want to answer. And please, I would come to the panel. They have been listening. But Larry, yes, go ahead.
I could spend 3 hours explaining to you how we already use that information in countries. I think the issue, first point, yeah, this discussion is framed as looking at global indicators. But in my mind, what global indicators are intended to do is monitor countries' progress in various areas, whether it's impact or coverage or quality. That's what indicators should be. And I would say on the vector control side, there's a very good correlation between what's important at global level and what's important at country level. It's the number of people sleeping under bed nets, right? You know, that's important for a country to know, and that's important for the global level to know. And I think that's one of the problems, is there's a mismatch between what global level is interested in looking at and what country level needs. And I think we can bridge that gap. So and similarly, there are multiple methods for collecting information. So there's certainly HMIS data, and your HMIS data is probably not going to be the place where you get information on quality. But I can tell you about 12 countries, including many of the countries sitting in this room, that have large-scale quality improvement programs that collect mountains of good quality data on the quality of service delivery, of the quality of microscopy. And I think it's a question worth at least exploring. Do some of those indicators, are they worthwhile monitoring, not just at country level, but at global level? I don't have an answer to that right now. I think that should be part of the discussion. Certainly it sounds like it's important. I also very much appreciate what I've suspected also is a lot of confusion around the definitions. What is a presumed case? Because, the way we've been looking at it is a presumed case is someone you suspect has malaria. And then for those patients, you want them all tested, right? But from what I've heard, what countries are looking at presumed cases is a very different perspective, which just points to the fact that there's no clear definition of what it is or what a suspected case is. So this has been wonderful because it really, I think we've heard a lot of perspectives, some I hadn't heard before, that I think really drive home the need for some better definition, some better clarity, and possibly some new indicators, and possibly retiring some old indicators. So, you know, I think we definitely welcome that.
Thank you, Larry. I think we are saying the same thing. Those quality things are important and needs to be done and part of the system and what countries should do. But we're talking about what do you need to monitor and escalate to global level, and how do you use those information? I turn to the panel. Maybe we'll start in the order in which presentations. No, you've been listening quietly and patiently, please.
Thanks. The feedback from the countries and other people who are there, all very interesting. There are some things, I think, that are reasonably well defined, but not well communicated, right? For example, there's no reason why there should be any confusion between suspected and presumed. You have suspected, you will test some of them, some of those will become positive. That's your, you know, the malaria case that has been tested, suspected case tested and is positive. Then you have presumed, which emanates from suspicion. You don't have the diagnostics. Then you use other clinical symptoms to say this is most likely to be malaria. And then that leads me to countries arguing the case that presumed cases should be retired because it actually undermines your policy of test and treat. I argue differently. If you look at the annex of the World Malaria Report and you pick the information from your country, for majority of countries represented in this meeting, you will see thousands, if not in some instances, millions of presumed cases. The reason why this happens is not because health workers don't want to test these patients. It's because there's a huge and frequent stockout of diagnostics in a large number of countries. And if you do not capture the cases that you were not able to test, but you had to treat because you thought they had malaria, then you give this false impression, which undermines your own ability to improve your systems, before even we talk about its global significance, to say how well you're doing in the diagnostic space and how frequently you're doing well in the diagnostic space. And then in terms of interpretation of routine data, if you give me 100,000 tested, 10,000 positive, but actually there are 50,000 presumed who are treated as malaria, but I don't have that information, I will simply underestimate the burden you're potentially dealing with. And you would be underestimating the burden you're potentially dealing with. And that's before even we start talking about people who don't seek care and people who seek care in the private sector who are largely treated without diagnosis. So, and this is what I meant when I was saying it's very easy to define an indicator. It's important to actually determine that the systems in place are either easily adaptable to collect that information or are able to collect readily that information. And if that's not the case, and we determine that an indicator is important, that we're able to put the right investments to ensure that that indicator is collected. It's a huge problem understanding the level of coverage and the quality of coverage of case management. Trust me, the pathway, and I'll tell you this for free, the pathway is not redefinition of indicators. I'm sure there are things we can improve. The pathway is systemic, and the right investments, changes in workflow, supervision, feedback, all of that's the real pathway. So I'll stop here for now.
Okay, thank you. Molly?
Again, echoing Noor, I think a huge part of this is that, a huge part of this is talking about quality of care. And that's not something you're going to put into the register. We're not going to be able to measure our way out of malaria. We need to be able to put systems in place where things can be taken care of. There can be triangulation of information. information. We can understand if there is a problem with the healthcare provider not knowing the definition of what suspect is, not suspecting it correctly. I think Dr. Stella from Benin was showing us exactly some of those problems in her earlier presentation. So really understanding what those pieces are, tied with all of the information from stockout, tied with whether people are coming in at the rate we want. And we have different ways of measuring that. What we maybe aren't doing as well as triangulating that information and making decisions off of that information. So how much does supervision data, for example, is used at the site, at the point, and that should be, but how much do we know systematically what are the issues that the supervisor are coming up against? How much is that information fed back? And how much can we look at some of our case management cascades with that information together with it, with the stock information together with it? So I think the indicators themselves, and always, you know, there can be a look at improving those, but one, we need better methodologies that will get us this information quickly, and perhaps supervision is a good way to do this. In the SMERG, we had a whole revision of kind of a supervision checklist, and we're really trying to get some movement on that, and it kind of fizzled out and died. I'm happy to try to reintroduce that because I think it's a really important piece, a really rich data set, where not only are you using it to solve the problems on the ground at the time, but you can really extract that information as well and see what some of your more systemic issues are, and then look at the information that you get out of surveys and the health-seeking behaviors of surveys, and looking at the stock information and looking at all these other pieces of information. But it takes some work. Like, you know, one of you noted, putting all that information together, having the systems to get all that information together and make decisions off of those triangulated information. We have tons of information. It's how do you put this together to make decisions?
Thank you very much. And Patrick?
Well, thank you very much. I think so many of the panelists have already highlighted the important comments that we heard here today and the value of understanding that we have multiple different sources of information that can be useful for understanding case management, that might rely to some extent on our routine health information systems, that might in some cases require that we interrogate supervisor checklists or data or quality of care project data systems. And of course, we'll probably still have the opportunity to obtain some useful information from population-based surveys. One of the things that we encountered in looking at some of the data on access, who is accessing care, is that our population-based surveys, for the most part, have focused on children under 5 with fever. And we really don't have information about older children and adults care-seeking practices. And probably as we think about revising global indicators, there may be a need for some attention to different age groups, because as Larry pointed out, the portion of children who accessed a health facility and got a finger or heel stick often turns out to be a proxy for our estimate of the coverage of diagnostic testing, not just for children, but for the whole system. And that probably could be addressed. So thank you very much, and appreciate this effort and the opportunity to connect with you.
Thank you very much, Patrick. Thank you, panelists. I'm looking at time. We are way past schedule. I just want to, some few reflections, and then maybe when we look at quality of care, we use it a lot now, which is great. And what does that mean in practice? Someone who is sick, able to access health care as quickly as possible. And when he gets to the facility, they are able to make the right diagnosis And that diagnosis has to be quality assured, which is a different process. But it's able to assess the right diagnosis, and the health worker is able to make the right diagnosis based on that test. And that patient gets the right treatment and the right follow-up. That's quality of care. It's not malaria specific. And most times when we talk about quality of care, it's a systemic issue. And that's why I asked the question initially. I've been in case management for a long time. Most of the issues we're discussing here are systemic issues, which the malaria program do not have a direct control over. When you talk about stockouts, of course, we're looking at anti-malaria medicines and stocks. In most countries, except you have a parallel system, which it was the Global Fund that helped to bring that in. The supply chain of your anti-malaria medicines is a reflection of the overall supply chain system. Yeah, there are some times when you have a parallel system that runs, but of course that you have to support through projects or whatsoever. Even this whole issue of malaria programs getting involved in supply chain came with the ACTs. Before, quantification of SP chloroquine was outside malaria. Of course, a good thing that we're getting. So the reason I'm raising this is I think we also begin to need to have a different approach to how some of these issues should be solved. Some of the things we are raising here has to do with supervision. Except you are going to plan and propose your own malaria-specific supervision, which you do. But for the overall system, we need to have a system improvement. I use Rwanda as an example, and I keep saying it. The results we see is because of the functionality of the health system from bottom up there, and not just malaria. You don't have a Ministry of Malaria, you have a Ministry of Health. Malaria is part of that Ministry of Health. But having said that, there are things we can do specifically for malaria. And I guess what is obvious today and what is clear is that, yes, we need to keep collecting indicators, but beyond indicators, beyond data, there are other things that need to be done to enable us to deliver case management effectively. So I would hand over to Larry.
Yeah. I guess my concern is that one could interpret your comments as a recommendation of helplessness.
Sorry.
Let me finish. You've had your chance to talk.
Yeah, I would interject.
Let me talk.
Because that's
let me talk. In many countries, malaria is the #1 reason for attendance at a health facility. The malaria program sits within the Ministry of Health and has the ability to advocate, collect information, which many parts of the Ministry of Health don't have, on things like stockouts. We might only collect information on malaria drugs, but it may be a bellwether of what other health systems issues are. You know, I think none of these programs function in a complete silo. They work with other parts of the ministry, and if we can use our information to inform the broader Ministry of Health, whether it's the supply chain department or the health services department, that's something we should do. And that's something that would benefit everybody. And I'd also add that in many countries, it's not just malaria supervision. Ghana has now integrated supervision. Other countries have layered COVID supervision on top of malaria supervision. So there are opportunities to look beyond just our own program. And I don't want people to walk away and say, well, quality of care is a broader systems issue. We can't do anything about it, so let's just throw our hands up. I just fundamentally reject that notion.
Yeah, thank you very much. I agree with you completely. No, I think we should be clear. The thing is, when you look at where we are coming from, maybe I should have extended my statement to what Larry said. The point is, we need to begin to tackle this at the right places. And malaria, yes, you can be the starting point to tackle that. But you cannot tackle that within the malaria program and you remain with the malaria program. That is the point. And we have done that for years. And that's what we have been doing for years. We keep speaking to ourselves. We don't look at it beyond malaria program. We keep looking at malaria program managers. No, we need to begin to leverage what we have to take it outside of that. And I agree with you completely. So it's not a matter of folding your hands, but we need to think outside the box and to say, how do we use the advantages and all that we have? How do we use the fact that we have access to resources, which some other programs do not have? How do we use that to leverage the whole going forward? And I think that's the point. And I agree with you on that. So, it's not that we throw our hands up, but we should know it's beyond just how we have been trying to do things over the years. We've done this, we say the same things for how many years? Yeah. We're still where we are. So we need to think differently and outside the box.
Yeah. Oh, thank you, Peter. Thanks to all the panelists and specifically on this panel, but throughout the meeting. Thanks to you all for your excellent. Before you go, we're all, unfortunately, this meeting is going to end tomorrow, and some of you are going to start heading home. And for some of you, you're going to need a COVID test before you leave because the country you're going to requires it. So we want to get a count because Dr. Aline and the RBC have agreed to bring COVID testing here to the hotel to do the testing. Probably we'll have to do it tomorrow, but we want to know how many people need tests. Fortunately, my country, we don't need a test anymore, and most of just my understanding is most of the airlines are basically only requiring it if the country requires it. But it's important. If you don't know now, you need to find out very soon, because the last thing we want is you arriving at the airport only to be told you need a COVID test. Where are we? Lena and Adam, go see them. We'll start a little sign-up sheet and let us know if you need a COVID test before you leave. Okay? And thanks for staying way over time.